rupture of membranes, and dilatation of cervix. When we see on the outer aspect, we can find that everything is involved in the labor, but what actually implies that the labor is progressing is a question. So how do you assess the progress of labor? Anyone? All right, I'll only talk. First, when we see this option, increased number of contractions. So does that indicate that increased number of contractions means the labor is progressing? Obviously not. So when we see the explanation here, progress in labor is still assessed based on 4 main signs. These are cervical dilatation or effacement, station of the presenting part, position of the fetal head, and strength of contractions. But being said that the cervical dilatation or effacement, it is not that the cervix, let us assume that cervix is dilated like 8 centimeters or 7 centimeters and is not progressing any further, which means that the labor is not progressing. Am I right? So what we have to consider now, increased frequency of contractions. So the labor pain, when compared with the false pain will not increase in the frequency of contractions, whereas the actual labor pain will increase in the frequency of contractions, but there will be specific time gaps between the frequency of contractions. However, the frequency of contractions increases. Increased severity of pain is not an answer, because the increased severity of the pain indicates that there is some problem in the abdomen. That's why the patient is having severity of the pain, but the labor is not progressing. And next, the rupture of membranes. Rupture of membranes can happen in many conditions, like premature rupture of membranes. In premature rupture of membranes, if the premature rupture of membranes happen, it doesn't indicate that the labor is progressing. Even if the rupture of membranes have happened, we may actually need to do cervical dilatation by giving oxytocin. So rupture of membranes does not imply that the labor is progressing. And dilatation of cervix, as I said before, when the cervix is dilated for let us say 4 centimeters, 5 centimeters or 8 centimeters and is not progressing with the progress of time, then it is not called as progress of labor. So the correct answer here is increased frequency of contractions. Hope you understood. If you have any questions, you are welcome to ask.
Okay, I have a question regarding this.
Yes, doctor.
If the STEM content about the fetal fibrosis.
Can I know who is talking?
I'm Dr. Puar.
Okay.
Okay.
Yeah.
My question is the STEM content the fetal fibronectin? In that case, what would be the answer?
Sorry, I didn't get you, doctor. Sorry.
Fetal fibronectin. If the
fetal fibronectin, yes. Yeah. Fetal fibronectin indicates that the amniotic sac has broken, but it does not imply that the labor is progressing. The question is asking about which of the following implies that the labor is started.
Yeah.
So the fetal fibronectin will also be there in premature rupture of membranes. Did you get my point?
Okay. So question is about the labor started. So
yeah,
you should always use the frequency of contact. Okay?
Yeah, labor is always because of the uterine contractions. It's not about the breakage of the amniotic sac. Like in premature rupture of membranes, the rupture has happened. So when the rupture happens, there is fetal fibronectin released, but which will not indicate that the labor is happening.
Okay, if the cervix is dilated is the positive content that the diameter of cervix is more than 4 centimeters or 5 or 6 centimeters. In that case, you can choose frequency of contact or.
So the cervical dilatation varies between the primigravida and the primigravida and the multiparous ladies. So if the cervical dilatation is like corresponding to 1 hour to 1 centimeter, then it is called as a labor is progressing in terms of primigravida. And if the labor is progressing, if the cervical dilatation is like more than 1 to 2 centimeters for 1 hour, should be there in the multiparous lady to say that the labor is progressing.
Yeah.
If the cervix has dilated till like so the cervix dilatation has progressed from 1 centimeter, 2 centimeter, 3 centimeters, and 4 centimeters, But after reaching to a certain point and it is not progressing anymore, if it is like 4 centimeters and even after 2 or 3 hours it is only 4 centimeters, then we will not call it as a labor is progressing. Understood?
Okay, so the first sign of the labor is started is the increased frequency of contraction.
It is not the first sign, doctor. The question is the question which of the following implies a labor has started.
So one thing I want to know that if we asked about the first sign that the labor is started, can we choose the fetal fibrillation is the it contains this cell?
No, doctor. Actually, the labor is always related to the uterine contractions, the true uterine contractions. It is not related to the rupture of menses.
Okay. Thank you.
Hope it is clear. Any other questions? Shall we go to the next question?
Yes, next. Yes, please.
Okay. So next, the primary gravida gave birth at term to 3,200 gram baby, normal vaginal delivery without any complications, and there was slight meconium staining of liquor. So the important point to be underlined here is a slight meconium staining of the liquor. Next, baby was normal at birth with normal heart rate. After 1 minute, suddenly baby stopped breathing. So after 1 minute, the baby stopped breathing, and the heart rate has decreased and the baby got cyanosed. What is the most appropriate next step? So I'll show you a flow chart. This is a flow chart which is commonly followed in all the Australian hospitals. I have these two different kind of questions. The one which we usually follow in the medics, and the other one is the one which we usually follow in the Australian hospitals. So here is a flow chart. This flow chart will be there in all the hospitals in the ICU, pediatric ICUs. It will be hanged on the walls everywhere. So newborn life support. So the first we'll check, is it the term gestation? So what does the question say? Does the question say anything about the term or preterm? No. So here
the birth is at
term. Okay. So that it is at term, and the baby is breathing or crying. Baby is not breathing. Is the baby in good tone? No. The baby stopped crying and is not responsive. The baby has cyanosed, which means the baby is not in good tone. So here the answer is no. Then next, go to the next step. Maintain normal temperature, ensure open airway, and stimulate. So here the first steps are not there in the options. So next we have to go to the other options, like where we have to check if the baby is cyanosed and baby is unresponsive. It indicates the baby is not in normal temperature and there is no open airway and the baby is not stimulating. So next we have to check is the heart rate. Is the heart rate 100 or the baby is gasping or apnea? Here the baby is not breathing, which means apnea. So apnea is there. So for what we have to do, we have to give the positive pressure ventilation with SpO2 monitoring. So how do we give the positive pressure ventilation? Bag and mask is the first method of giving the positive pressure ventilation. Okay, and then we'll again check if the heart rate is 100, heart rate is below 100, and if yes, then ensure open airway, reduce leaks, consider increased pressure and oxygen. Even then, when we have given the first bag and mask ventilation and we have checked for heart rate, if the heart rate is below 100 again, even then we have to give the continuous positive pressure ventilation first and then consider intubation. We never have to stop bag and mask, because bag and mask is very easy. You will have a mask and you will have an oxygen inflator where you will be like the bougie one. You will be puffing it and giving the oxygen, which is an easy and an immediate procedure. Intubation in pediatric age group will only be done by the specially trained pediatricians or pediatric nurses. It will take time. You will have to alert the pediatric team, and then the pediatric team will come and then they will intubate. Till then, what you have to immediately do is start the bag and mask ventilation, which is everywhere present. So you should not miss that logic thinking about intubation. Yes, doctor?
So we will repeat bag and mask again.
Yes, you have to repeat. You have to keep doing bag and mask until the intubation team has been arrived.
Okay. Yeah. Got it.
That's what it means. Okay.
Yeah. Okay.
And then you will again have this heart rate. This heart rate below 60. So if you have given intubation and also the bag and mask ventilation, heart rate should improve. Even though giving the bag and mask ventilation and also intubating the patient, the baby's heart rate is not improving, which means you have to start doing CPR. You have to stimulate the heart externally, and as you have intubated, and you have to start on 100% oxygen as well, and you will start 2 IV bore needles and start giving the IV fluids. Okay, and then you will again check the heart rate. If the heart rate is below 60, then you will give adrenaline, which is the same step in adults as well, isn't it? And this is a simpler way. This is a simpler process when the baby is in term gestation and the baby is breathing. Yes. So what you will have to do? Maintain normal temperature and ongoing evaluation. So maintaining temperature in pediatric age group is really important. It's not that you have to you have to close the baby with all the clothing so that the baby has adequate high temperature. Even doing the high temperature response, even leaving the baby without any clothing is also dangerous to the baby. So what you have to do, you have to maintain the normal temperature of the baby. So ensure that the baby is covered normally, not with extra clothing or very light clothing. Ensure the baby is covered normally. If all these options are not given, and the question says what is the next appropriate step, what is the next step, then what you have to mark, maintain adequate temperature of the baby. Are you with me?
Yeah.
Okay. And so you will maintain adequate temperature. If the baby is everything normal, you will maintain the temperature. And after giving the continuous positive pressure ventilation, if the heart rate has improved above 100, if the heart rate has improved above 100, and we will check if there is labored breathing or persistent cyanosis. If there is labored breathing or persistent cyanosis, then again you will ensure open airway SpO2 monitoring. Consider CPAP. CPAP is nothing but the positive pressure ventilation, doctors. So don't confuse, these two are the same, which is bag and mask. And once the baby is resuscitated and there is increase in heart rate, you will send the baby to the post resuscitation care. Sorry, there is some background noise from me. Can you please mute yourself? Thank you. So, any questions for this question? Do you want me to explain again?
Okay,
So the answer is.
I have a question regarding you. The question asked about the meconium stained baby, but in the chart, I have nothing about the meconium stain. Is the question said slight meconium staining in the leg?
Yes, yes.
So if it is meconium aspiration syndrome, do we give the bag and mask ventilation at initial, because it can go the further deeper meconium?
So, no, doctor. If it is meconium aspiration, first you will do is nasopharyngeal aspiration of meconium. You will pull out all the meconium, and then you will give the bag and mask ventilation. Every time it is bag and mask ventilation, don't confuse if it is meconium stained, meconium aspiration. Every time it is bag and mask. See, the flowchart. This flowchart is sticked on the walls of all pediatric departments. And this flowchart doesn't say that if it is meconium stained or non-meconium stained. You will always have to give the positive ventilation.
The question is just that the slight meconium stain.
Yes, doctor. Don't. I'm telling you not to worry about if it is meconium stained or not stained. Always you have to start with the easy process. The easy process is you will have the bag and mask ventilation available next to you. So pick it up and start giving the oxygen. Even if the meconium is aspirated, the oxygen will help the baby in breathing normally. If you are waiting for the baby to be intubated, the baby will lose oxygen percentage in his body. It's so simple logic.
Hello, doctor. I have a question.
Yes, doctor.
What if, like, in your question up there, this patient already had heart rate? Okay, we have not yet, it's not been indicated, but in case, let's say, same scenario,
Yes.
heart rate was less than 100.
Yes.
Right?
Even if
Then
the heart
bag and mask will not help us first step, right? It will be
no,
intubate.
no. See here, doctor.
I mean,
Even
sorry, less than 60. Sorry about that. Less than 60.
Less than 60, yes, that's a good question. Less than 60, you have to directly intubate.
So basically, it all depends on the heart rate.
Yes, yes, doctor.
But like in this one where it's vague, then we still stick to a bag and mask.
Yes, yes.
Thank you, doctor. Thank you.
Is everyone clear?
And the weight of the baby doesn't have to do with it.
No, it doesn't matter. Only only keep this flowchart in your mind. It is only talking about heart rate. Heart rate and baby, is it term gestation or not, breathing or crying, and you cannot see anywhere the baby weight. Are you able to see baby weight anywhere?
No.
Yeah. This flowchart is very important, doctor. Please remember this flowchart, and I will assure you, you will do all the questions related to the newborn resuscitation correctly.
Okay, thank you. So is this table available, or is there any place where we can download this table from? Or
I will give you this file, doctor, after.
Okay.
So the answer is B or C.
I think C.
So they are asking most appropriate next. Why not B? Because we need to aspirate first, okay? According to that chart, can we go to the chart?
Yes.
It says maintain normal temperature, ensure open airway. So why not B?
It's a simple logic, doctor. If the baby is actually not breathing, there is heart rate has decreased, and baby is going into cyanosis. Now there is no point in pulling out the aspiration. First, you have to give the oxygen, stabilize the baby, and then do everything. Oxygen is very important for the baby.
Okay.
It's so simple. Hope you got my point.
Yes, doctor. We'll move on to the next one.
Is everyone clear? I want you to be clear with this. Thank you.
Yeah.
Okay, next question.
Doctor,
Yes.
if the heart rate is from 100 to 60.
Hello everyone, this is Dr. Shariar.
Go for bag and mask.
I think
If less than 60, then direct intubation, right?
Yes.
Because there is a question regarding this.
dear doctors, I think you should move forward, I think, to the next question, because you have 3 hours, and as much as possible Dr. Priyanka will try to cover. So also give her a scope, because I can see already 20-25 minutes past, like, because so 1-2 question is appreciated actually for one thing, because the file will be remaining later actually. So try to finish. So try to give her space, like like, so that she can move more fast. So usually expected to have one question, like with one particular question. So, thank you.
Okay, next question. So mother in 41 weeks plus 3 days with no abnormality, previous child born by LSCS due to obstruction of labor. Bishop score is 2. Induction, so options are, what do you do? Induction with prostaglandin, induction with ARN, LSCS, admission for fetal examination, CTG after 1 week. So here, doctor, even if the previous child born by LSCS, you will have to always focus on the Bishop score first. So see the Bishop score. If the Bishop score is 0 to 2, then what you have to do? You have to give the prostaglandin in the form of pessary or gel in the posterior fornix. If the Bishop score is more than 5, then you will give prostaglandin at a later stage, or you will do amniotomy or amniotomy. Okay. So what is your answer here? The Bishop score is
A, induction with prostaglandins.
Induction with prostaglandin. This flow chart is very important. You will have to remember this flow chart. There is no other way.
What do we mean by for the second one? If it's more than 4, you say for prostaglandin at a later time. That means there's more cervical dilatation.
Yes, you will wait, and then if it is not progressing, then you will give prostaglandin or amniotin.
Oh.
Okay, and usually all the questions are coming from just these 2 boxes. The questions are not progressing any further.
Okay.
Okay, and if you want to see if the labor, after giving the prostaglandin, if the Bishop score is 0 to 4, and after giving the prostaglandin, if the labor has not established in 4 to 6 hours, then what you will do, you will again check the cervical score, which is nothing but Bishop score, if it is 0 to 4 or if it is +5. If it is 0 to 4, then again you will repeat the step from here, and if it is +5, you will progress to amniotic. And even if after 12 hours, if there is no change, then you will do cesarean section. Okay. Next question. Any doubts here? Just remember this flow chart, you will get through it. Okay. Next question. A child has jaundice on the 3rd day after birth. Now baby is 6 weeks and still have jaundice. What is the cause? So can anyone tell me what is Gilbert's?
Gilbert's is like a disorder with unconjugated, where the unconjugated bilirubin is increased.
Yes. Yeah. So the baby will have an inborn defect with increase in unconjugated bilirubin, but the unconjugated bilirubin will be higher only when the baby's immune system is low, like when the baby is having cough or cold, or the baby is having flu, or the baby is having fever, any immunosuppression drugs, then only the baby will have this unconjugated hyperbilirubinemia. So this is called Gilbert syndrome. And biliary atresia. So if the baby is having biliary atresia, the baby will be having jaundice from the day the baby is born. And the question says the jaundice is on the 3rd day after birth. So the baby was normal for the first 3 days. Understood. So this is not biliary atresia. Biliary atresia is a defect with the biliary tract. So the baby should have the jaundice from the first day of the birth. And how about physiologic jaundice? Can anyone tell me what is physiological jaundice? Yes, doctor, please. Anyone tell me what is physiological jaundice? No one?
The jaundice which appear after the 24 hours?
Yes. So, see here. So, physiological jaundice can appear anytime. It says after 4 days, but it is actually after 3 days. And pathological jaundice will be there on the 1st day and 2nd day of the jaundice. So, pathological jaundice becomes biliary atresia. Physiological jaundice. So, can anyone tell me what is the difference between physiological jaundice and breast milk jaundice?
Breast milk mostly on 5 to 7 days like that.
Yeah. Apart from the days, the physiological jaundice is because of the immature development of the biliary tract, because the baby is born recently. The biliary tract is still developing, and so that the baby is not able to digest whatever the bilirubin is produced, and so the bilirubin is increased in the body, which is called as physiological jaundice. Why physiological jaundice? Because it is the problem with the biliary tract, which is still developing, but there is no pathology underlying. The baby will be normal once the biliary tract is developed. But unlike pathological jaundice, like the biliary atresia, there is a problem with the biliary tract. That is why we call it as pathological. There is some pathology. Physiological is nothing but normal. So physiological jaundice can happen from any day, like the 3rd day or 4th day, and can persist until 6 weeks or 7 weeks. It depends on how fast the baby's biliary system is developing. Understood? And physiological jaundice will have unconjugated hyperbilirubinemia, whereas the biliary atresia will have conjugated hyperbilirubinemia. Got it? and the total bilirubin will be always less than 20 in physiological. Just 3 points, doctor. The physiological jaundice and pathological jaundice. Physiological jaundice will be there. Will start developing at later stages, like second or third day or the fourth day. Yes, pathological jaundice will be there from the first day, and the unconjugated bilirubinemia is seen in physiological. Conjugated bilirubinemia is seen in pathological. Bilirubin level is always less than 20, and in pathological, the bilirubin level will be higher. The total bilirubin. Is it clear?
Yeah, clear.
Okay. And next question. A pregnant of 37 weeks gestation comes with complaints of reduced fetal movements for last 24 hours. Now CTG is done, it was normal, and patient was sent home with reassurance. She now comes again after 3 days that she is not feeling any movement. What's the most appropriate next step? So, can anyone tell me the answer for this, please? I want to know what's your understanding for this question.
I think the most appropriate next step will be we will try to reassure and counsel and make the mother calm.
No, doctor. See, the patient has already come to the hospital, and the patient has been already reassured, and she has come back after 3 days. She is not feeling any movements.
Sit immediate.
Answer may be immediate CTG.
Yes, that's good. It's immediate CTG. Why immediate CTG? Even so, the patient once came to our clinic, and then we have sent her home that, see, all your fetal movements are normal. I have done CTG and it is normal, so you can go home. And if you are not feeling any fetal movements, please come back. Now, after the patient has come back after 3 days, now without doing any test, can you reassure? Even in the first step, we have done CTG and then reassured. Now, can you reassure without doing anything? It's just a small trick here. So even in the first step, when the patient came, we did CTG, and then we thought, okay, CTG is normal, so there is nothing abnormal with the baby. So we have reassured. But now the second time when she came, we cannot just reassure. We have to do something.
Because baby is not, she's not feeling any movement, like fetal movement. So how can we say, how can we reassure her?
Yes. So every time you have to check, because see, everywhere the mother and baby are very crucial. You have to check them. Whenever the patient comes with any problem, please put your stethoscope, palpate for the fetal heart rate, and do necessary investigations every time. So immediate CTG. Obstetric ultrasound. In Australia, the ultrasound has a waiting period, doctor. So you cannot make the patient wait. CTG can be done in the clinic itself. And reassurance, without knowing anything what is happening with the baby, you will not reassure. It is a blunder. And amniotomy, without checking how the baby is or what is the problem, you will not directly induce any amniotomy, and you will not induce with prostaglandins either. Clear?
Yes, sir.
Okay, so there is a small flow chart here. So first presentation, forget about whatever the presentation is. We'll see from here. So the first you will auscultate. Every time auscultate. If there is an option for auscultate, what is next appropriate step? Auscultate the tummy. Okay. And so you will check fetal heart rate. If you will check for fetal heart rate by checking CTG, and then you will see if the normal CTG, then reassure. If the CTG is not showing any reassurance, then you will see. You will do ultrasound to check for all these AFI, morphology, and everything. Okay. CTG is the CTG is the second step after fetal auscultation. Because fetal auscultation is not there in the question, you are choosing CTG. Understood?
Yeah.
Okay.
Okay.
Any questions still here?
No.
Okay, great. Next question, African circumcision lady, antenatal checkup, a female genital mutilation. So it is very common with some of the Aboriginal people and also the African people that they will have the female circumcision. It is like this a traditional thing. But do you think this female circumcision will have any problem with conceiving or any problems with becoming mother?
No.
I think it depends on the grade of the fetal, the FGM, because in my practice, sometimes when it's 3 to 4, grade 3 to 4, then you are unable to do vaginal delivery. You have to do a CS.
Yes. So if choosing vaginal delivery or cesarean section comes at a later part, but when the baby is coming for, but when the patient is coming for antenatal checkup, what you will offer? You will offer the best basic antenatal care. What comes in basic antenatal care? Like full blood examination, all the blood tests, all rubella examinations, torch examinations. So first you will start with all the basic investigations and then proceed with ultrasound, and also do the transvaginal ultrasound, and then you will see what grade of fetal circumcision, what grade of circumcision does the patient have. And then you will decide when the patient is approaching to the labor, isn't it? So the first care is the basic antenatal care. Just that simply. Clear?
Yes, doctor.
Any questions? Any questions?
No.
Okay. Next, lady working in a daycare center. She's 7 weeks pregnant, exposed to rubella child. She was fine, but after researching on internet, she is worried now. What advice you will give her? So rubella is very, rubella is not very common, and if there is a threat that the patient is exposed to rubella and the patient is trying to conceive, we will ask the patient not to plan for pregnancy until 3 months, isn't it?
Yeah.
And by any chance, if the patient has already become pregnant and she says that I am exposed to rubella, then what we'll do, we will immediately check the serum IgG levels of rubella. If the rubella is positive, then we will give the patient 2 options, like either to terminate or to continue the pregnancy under the patient's will. But we will offer the termination because rubella is very dangerous. But before doing anything, before advising anything, if the patient is concerned or if the patient wants to check that she is having any rubella, we will always offer IgG rubella test. Clear?
Yes.
And rubella infection will only happen like in the first month or the second month of pregnancy, and she is already 7 weeks, like she has passed 1 month. Now there is no chance of having rubella. If the patient is like 7 weeks or 8 weeks, you can always reassure her that see, the rubella infection will happen only in the early stages of the pregnancy, but you are already at the 7 weeks and now you are worried that you are having rubella. If you have rubella, you will have some problems with your pregnancy, but your pregnancy is going very well, which means that I'm not thinking you are having rubella. You will try to reassure first, and you will ask if the patient has taken vaccination before conceiving. And even if the patient is not agreeing and she's like, oh, I'm very worried, then what you will do, you will suggest the patient to undergo IgG rubella test. Okay?
So if the same question is at 7 weeks of pregnancy or anything more than 7 weeks pregnancy, and if reassure is there, we have to go for that. Right?
Yes.
Okay. Is there a role for IgG in this? Like if patient is positive and then she's deciding to continue the pregnancy, do we give immunoglobulins?
No, there is no role for immunoglobulins here because the baby is already affected.
Mm-hmm. No.
Yeah, you will not get back the changes.
Mm-hmm.
Okay. When we will give them vaccine? Before conceiving, before 3 months of planning for pregnancy. Okay. So, as with any infection, IgM indicates a recent infection, like 7 to 10 days of infection. IgG will test like long-term infection for more than 1 month. Okay, that is the one which you have to remember. And these are some of the effects on fetus, which is not needed to remember. And vaccination is only advisable before getting pregnant. See, do not vaccinate during or within 3 months of proposed pregnancy. Okay. Is it clear?
Yes.
Yes.
Okay. You can check the links. I'll give you the document later. Next, after 5 days of normal delivery, sudden passage of clots. So cause. Any idea about what the patient is going through?
Yeah, retained products.
Retained chronic. Yeah. So why not it is endometritis or cervical tear?
Endometritis will present with high fever, abdominal pain, and none of that is mentioned.
And cervical tear, cervical tear, cervical tear, the patient will be passing the blood from the day she got delivered. But here there was sudden passage of clots after 5 days, which is very common with retained products of conception. As you said, endometritis, there will be high fever along with abdominal tenderness. Yes. Any questions with it's a simple one.
No.
Okay. Next, lady with retroverted uterus, on examination the uterus is floating. Can someone mute yourself, please? Okay, lady with retroverted uterus, on examination the uterus is floating, want to conceive, what to suggest? So the options here is do surgery for uterus and intracytoplasmic infusion, and the next one is wait for 12 months. So there are like I have found like 2 different questions here. Like women present with diagnosed retroverted uterus, she is unable to conceive for 6 months with effective intercourse. So here the question says effective intercourse. Here the question will not mention anything about intercourse. So in this question you will have to ask about their sexual life too. Understood? If there is option for any incomplete sexual life or proper sexual life, then you have to choose that. Doctor, what is it? There is some disturbance. Can you please mute it? Okay. So next question is, a patient consults you in the first week of her pregnancy. She is found to have a retroverted uterus. You should advise. So sleeping on chest, adoption of chest knee position, all these don't work, doctor. Distal correction and insertion of Hort Smith pessary and emptying the bladder every 4. This will not work. Emptying the bladder every 4 hours, no treatment. So for the retroverted uterus, what is the best treatment? Any idea? So this inserting the Hort Smith pessary is only when the patient is having some problem while walking or some discomfort and is not able to continue her daily life activities, then only we will prescribe for pessary. Otherwise, there is no treatment. We will just leave it. Retroverted uterus is uncommon, but this retroverted uterus is present in many of the patients. So the retroverted uterus, as you see, this is the uterus and this is the rectum. It can sometimes impact on the rectum, causing the fecal impaction. So that's when you will ask the patient to take some pessaries and get it back to the anteverted position. Got it. So here the patient is not, so these 2 stems does not mention that the patient is having any problem, but she wants to conceive. What does she want? What does she have to do when she wants to conceive? So see here, treatment of the retroverted uterus is the treatment for underlying conditions such as hormone. So you have to always check for the underlying conditions. The next is exercises. And the next is pessary, and the next is surgery, and the next is treatment. You'll again check for the any incarcerated uterus and give the hospitalization. So what you have to, from these options, you will not suggest to the patient to undergo surgery in the first step itself, or you will not say the patient that you have to go intracytoplasmic infusion without checking anything, without checking the partner. So the best option here is to choose wait for 12 months. Why choose wait for 12 months? In this 12 months, we can prescribe the patient to do exercises or to get checked with the gynecologist if she is having any underlying problems. Are you clear?
Yeah. Yes.
Okay. So now we'll see this question. Woman presented with diagnosed retroverted uterus. She is unable to conceive for 6 months with effective intercourse. Next step. Give her a diary for temperature chart. Why is the diary for temperature chart here important? It is irrelevant. Pessary after manual correction of uterus. This can be considered surgical correction of uterus and IVF. So the first step is always exercises. Next is pessary. So the answer here should be pessary, isn't it? And the next question is, the patient consults you in the first week of her pregnancy. She is found to have a retroverted uterus. You should advise no treatment, because the patient is not having any symptoms. Without symptoms, you will not give any treatment. Simple. Okay. So always get the patient checked for the underlying conditions. Next is exercises. Next is pessary. And if these are not working, then you will go for surgery. Okay. Am I clear?
Yeah.
Okay. Shall we go to next question, or do you want any break?
Go to the next.
We'll move on.
We can continue. Yeah.
Yes, good. So next, pregnant 32 weeks as part of program of flu vaccine, what options you choose? So can anyone tell me what are the contraindications for flu vaccination? Absolute or anything, whatever. Is there any contraindication for flu vaccination?
Immunocompromised patient.
We will give flu vaccination even in immunocompromised patient, doctor. There is no contraindications for flu vaccine.
Only the nasal form is contraindicated because that's a live vaccine, so you can't give under.
So flu vaccine can be taken by anyone. So if the patient wants a vaccine, give them.
Sorry, doctor, it's a live vaccine.
It's not a. It's an inactivated vaccine.
It's
Only
not a
the
live
nasal
vaccine,
form.
right?
Yeah, it's not a live vaccine.
It's not a live vaccine, doctor. So you can give the patient the vaccine. Okay. Okay. Next question. A woman had delivered normally was priming. Her labor lasts 16 hours. Placenta delivered normally and fully. Given methergine after delivery for placenta. So why do you give methergine, doctor?
The contraction of the uterus.
Yes. Next, 2 hours later, she had vaginal bleed, lost 1500 ml of the blood. On examination, abdomen soft, no tenderness. What is the cause? So, before selecting the option, what key point you have to select in the question to arrive at your answer?
Tenderness or no?
No tenderness. Yes, good. So there is no tenderness. So no tenderness will be there in what? Uterine
atony.
If there is rupture, definitely the patient will have tenderness along with blood loss. And if there is uterine inversion, the patient will not have pain, but then the bleeding will not be there, isn't it? So it is uterine atony. Okay.
So uterine inversion will just present a shock, isn't it? It doesn't have bleeding.
No. Okay. Any questions?
No.
Okay, next question. Patient 7 weeks of pregnancy, part uterus is 3 centimeters palpable above pubic symphysis. So can anyone tell me at what week of pregnancy the uterus is palpable above the pubic symphysis? 12 weeks. 12 weeks. 12 weeks is the correct answer. So here the patient is at 7 weeks, but then her uterus is 3 centimeters palpable above the pubic symphysis. So there is something abnormal. Either it should be wrong for dates or it can be molar pregnancy. Polyhydramnios is the complication of the third trimester, not the first trimester. Okay. Twins can be a possibility, but you will not, twins, the growth of the uterus will be more in twin pregnancy in the third trimester, but not in first and second trimesters. Fibroid can be a possibility, but the patient is not having any symptoms. Ectopic pregnancy will not present with the uterus high as 3 centimeters above the pubic symphysis. So here the two options can be considered is molar pregnancy. Oh, there is no wrong for dates. Yeah. So the answer is molar pregnancy. Is it clear?
Yes.
Yeah.
So the causes here include incorrect dates, constitutional large fetus, multiple pregnancy. Multiple pregnancy will be there. When multiple pregnancies can be seen on the uterus enlargement can be seen only in third and second trimester. Does that make sense? Yeah. Fetal macrosomia also in the late trimesters like second or third. Polyhydramnios mainly in the third. Clear? Uterine fibroids, the patient should have any symptoms. Uterine cysts, so the patient have any symptoms. Molar pregnancy is the main cause. So this 7 weeks uterus is like very small, but the uterus is 3 centimeters above. So uterus has grown, grown very large, which is more common in molar pregnancy. Okay.
So if there's a stem as wrong for dates, we always go for that, right? Like in the first trimester, that's.
Yeah, without doing any investigation, you will not select identiform mole. Simple. So you will select the wrong for dates option. Okay. Yeah. Okay. Next, postpartum breastfeeding mother with signs and symptoms of psychosis or depression, not clear cut, and insomnia. What to give? Which one is safe? So always, which one is safe in pregnancy? Clozapine. What is the side effect of clozapine? Agranulocytosis and weight gain. That's it. So under what classification does clozapine come?
Atypical and antipsychotics.
Yeah. Yes. Okay. Always remember clozapine in pregnancy. Okay. Next, woman came with history of postpartum depression. She was separated from husband before childbirth. Which one of the following would be the most appropriate action to do in her treatment? So she was separated from husband. And because she was separated from husband, she is having depression. Isn't it? So the second option, more breastfeeding baby and more attached to baby. If the patient is not able to develop relationship with the child, then you will choose this option. And you will not give the medication without any talk therapy. Always talk therapy first. Talk therapy, couple therapy, family therapy first. Always talk to the patient and then go for medication. Okay. So see, the John Murtagh also says this, the postnatal depression. So first is we always support, reassure, counsel. Next is psychotherapy or support therapy, support group. The couple therapy must involve partner. Always postnatal depression must involve the partner. Okay? Okay. And postnatal depression is very common in Australia. So you should always, there will be a question in your exam every time. It is so common here. Okay, next question. Woman 3 hours into labor, everything is okay. She starts bleeding, BP drops, baby pulse drops, reason. So options are placenta previa, amniotic embolism, coagulation, placenta accreta, and placental abruption. So what is the cause here? So I got this question in my exam, and first I chose placenta previa, and the second time when I read the question, I chose placental abruption. What do you think why I chose placenta previa and then placental abruption? Any leads?
Because the pulse of the baby drops.
Yeah, the pulse of the baby will drop in the cord prolapse too, isn't it?
Yeah.
Yeah, cord prolapse or cord breakage, but here there is no option, so I eliminated it. And then placenta previa is only a problem with placenta. Then why do the baby have to suffer? Yes, and then so placenta previa will have the the patient will have sudden gush of blood without any pain. And then amniotic embolism, the patient should have dyspnea. Sudden dyspnea, severe dyspnea will be there.
Yes.
And then coagulation, the patient will have all these septic causes like drop of BP, temperatures, dyspnea, everything. Placenta accreta, baby will not be affected. Placental abruption is the main, is the most common cause of bleeding in the mother and also in the baby, in which the pulse drops, apart from cord prolapse. In the cord prolapse, in cord prolapse, mother's blood pressure will be normal. Only baby's blood pressure will go down. But here the question says blood pressure of both mother and the baby is dropping, which means it is placental abruption. Are you clear?
Yes.
Okay, great. Next question. 16 weeks gestation, I don't know, week gestation, BP 145/90, headache, flashes in vision. So headache and flashes in vision. Where are you going into? Preeclampsia. Yes. So what findings will lead you to an emergency intervention? Emergency intervention? Yes, clonus and decreased ankle jerk. And what is the treatment for preeclampsia? So if the patient is having headaches and flashes and the baby is coming into the GP clinic, what medication will you give?
If the patient is hypertension, then we will give the antihypertensives.
Antihypertensive, so you will give hydralazine. Labetalol should only be given when there is monitoring. So labetalol should be given only when there is when the patient is in hospital. Okay. And MgSO4 should also be given only in the hospital because MgSO4 will cause what?
Hypokalemia.
And hyporeflexia. That's how you will check, no? So if the patient, if there is the eclamptic patient, you will always be checking the knee jerk or the ankle jerk of the patient because you will see how MgSO4 is acting. Okay. Next question. 32 weeks pregnant, not immunized, comes want advice. Her son, 8 years old, diagnosed having chicken pox. So same like rubella.
Yeah.
So you will always check the IgG status. Okay. Any questions for this?
If she is infected, then we can give her acyclovir, right?
Yes. Yes, this is there in JM. You can check. You can give acyclovir.
Can we give immunoglobulin in pregnancy in case of chickenpox?
Immunoglobulin only within 2 days, doctor. And immunoglobulin. So what JM writes here is immunoglobulin is not. There is some confusion with immunoglobulin every time. If there is no history of clinical varicella, do an IgG antibody test in mother. If seronegative, give varicella zoster immunoglobulin. Yes, yeah, you can give immunoglobulin within 48 hours. See, within 2 days, and also give immunoglobulin to immunocompromised. So you can give immunoglobulin to normal patients and also to the immunocompromised patients and to the pregnant. Okay, there is no contraindication of pregnancy or immunocompromised. immunocompromised state. Is it clear? You can give immunoglobulin to anyone within 48 hours.
Yes, yeah.
Yes. Next, 38 weeks lady wants C-section. What do you advise? So if the primary gravida comes to you and asks for C-section, what do you do? So first you will try to explain C-section is not always recommended. It is always better to go for a normal delivery. A C-section is only done when you are having some problems or the baby is having some problems. Okay. So without any problems, we never recommend C-section. Even when the patient is not listening and the patient wants to go for C-section, what you will say? Okay, I'll have to take another opinion of another doctor. That's all. So it is always advisable to take the help of the seniors or the other doctors, and then with the other doctor's consent, you will do the C-section. That's it. So you are safe. Okay. Next question. Woman has 5 minutes contraction at 26 weeks gestation. Her examination is normal. Pus is closed and no fluid in addition to steroid. What should be given? So preterm labor. So when do you call it as preterm labor? When the labor has happened after 20 weeks and before 37 weeks of gestation. If the labor has happened like very near to 20 to 28 weeks, there is still chance to, isn't it? You cannot deliver the baby then and there itself. You can still wait by suppressing the contractions if the patient is already having the contractions, or you can admit the patient and see the progress of the patient, and then if there is any problem, then you will deliver. If the baby has not reached 37 weeks of gestation, you will not deliver even if it is preterm. So you will admit the patient, give all the antibiotics, all the fluids, and then ask the patient to stay in the hospital until delivery, until 37 weeks at least. Isn't it?
Yeah.
So what is the management? So you will admit the patient and then consider tocolysis if the patient is having uterine contractions, and then you will give corticosteroids in case if the baby, because the fluid, because the rupture has already occurred, in case if the baby goes into delivery, the lungs has to be matured because the baby is only 27 weeks in our question. So we will give corticosteroids. Apart from that, because it's preterm, the patient may have some pain. If the patient is having pain, you will give paracetamol, or the other next option is antibiotic. Because the rupture has already happened, there is a chance for the bacteria to breach and enter the amniotic fluid. Clear?
Clear.
Yeah, sorry, doctor. There was a question which had 2 options. So it was confusing. Should you first give the antibiotics? I even posted in our group. Should you first give the antibiotics or you should give the corticosteroids for the lung maturity?
First, always corticosteroids, doctor. Always corticosteroids.
All right, thank you.
Baby is important for us first.
All right.
So if the tocolytics is in the same, then we choose tocolytics.
Tocolytics only if the patient is having uterine contractions.
Yeah.
Okay, without any contractions, tocolytics are not needed. Okay, clear, everyone. Okay, next question. See, again we got this question. Patient of preeclampsia, plan for induction of labor, cervical Bishop's score is 2. What to give? So please answer without seeing the flowchart.
Prostaglandin.
Prostaglandins.
So you'll give prostaglandin and then. So here the options are not just prostaglandin. So prostaglandin and ARM after 4 hours, prostaglandin and wait for 12 hours, Synto and then ARM. What will you choose? Is there any other option? No.
Because she's pre-eclamptic, should we go for 8 because we don't want to wait anymore?
Yes.
Yeah.
Yes, that's the logic here. Okay, prostaglandin and ARM after 4 hours. Clear? Next. A pregnant lady from Vietnam is presenting with pallor, jaundice and hypochromic microcytic anemia. The iron and the ferritin are decreased. What do you do? So iron and ferritin are decreased. which means she is having some kind of anemia, isn't it? So apart from anemia, will the anemic patient will have jaundice and jaundice? Will the anemic patient will have jaundice?
No.
No.
No, not just simply anemia.
So why does the patient have jaundice?
Hemolysis is going on.
Yes. Hemolysis. So what
From Vietnam.
Yeah, she's also from Vietnam, which is pointing towards some kind of parasitic infestations. Why is it not HB electrophoresis? Why is it not thalassemia?
If we consider electrophoresis for thalassemia, the ferritin levels should be raised.
Ferritin should be raised or normal, but here the ferritin is decreased. So we are eliminating the first option. And then iron studies, because iron is already done. Iron and ferritin had decreased. There is no need to repeat iron studies, isn't it?
Yeah.
And detection of blood in feces. Now, is it anemia of chronic disease or is it because of any bowel problem?
No.
No.
No, because why? Because she is having jaundice too.
Yes.
So we may think of malaria.
So nothing about fever, though isn't the question.
Yeah, she's not having fever, but then she's having jaundice. Maybe what happened is she has already passed the stage of fever and then the liver has got infected now. Okay. So it is necessary to do thick and thin film. Why do you do thick and thin films? Thick film for what? Thin film for what?
Malaria. Identify the malaria parasite and thin film to identify the which parasite of the malaria is infected by which one.
Yes. Correct. Next question. Mother comes 6 weeks postpartum, wants you to give you contraception. You see her file and it's written not to use any contraception. On inquiry, she tells you that her husband is against contraception and gets aggressive, but she wants to space out her babies. So she don't want contraception because her husband is not, but she actually wants. So here, not only here, everywhere it is. Forget about some of the countries like India, but in Australia, it is always the person's wish. If she wants to have contraception, it is her wish. Nobody can stop. Even if she wants to go for an abortion, her husband cannot stop her. Because it's her baby, she has the complete rights until the time of delivery. After delivery, it is a decision of both the parents. Got it?
Yeah.
So you will have to give her contraception as it's her decision. Okay. Next question. Previously, healthy woman came for antenatal 38 weeks gestation with 1 liter of blood loss. So at 38 weeks, she had 1 liter of blood loss. Low-lying placenta. So where do you see low-lying placenta? Placenta previa. And so it was seen at 18 weeks and then failed to follow up, and then USG was done. Now our examination BP is 170, HP is slightly low, which further process will help you for diagnosis. So it is very simple. Placenta previa is like low lying. So where is the head?
Head
is floating. So high head. Okay. Pain with bleeding. I'll give you the answers to other options. So pain with bleeding is not only consistent with placenta previa. It can happen with abruptio placenta, or it can happen with knee trauma. Yeah. And uterus tenseness. Uterus tenseness will happen with abruptio
Abruption,
previa. Okay. Absent fetal heart rate is not consistent with placenta previa. If the patient is having placenta previa, why do the patient's baby's fetal heart rate is absent? And uterine contractions, it is not consistent with low-lying placenta too. So if there is placenta on the lower end of the uterus, the head will be somewhat higher, so high head. Any questions?
No.
Next, a lady with spina bifida came to clinic at 8-week gestation, worried that the infant will have similar problem, but didn't take antenatal care before and no folic acid prior. So, the patient, lady with spina bifida, came to clinic at 8-week gestation. So she was having spina bifida, and now she is worried that the baby who will be born to her, will have the spina bifida. And she did not take any antenatal care before, and there is no folic acid also. So she did not take any folic acid, no antenatal care. Now she is worried at 8 weeks that her baby will have spina bifida. So what do you think? Spina bifida is like a neural tube defect which will happen in the first trimester of pregnancy, isn't it? It's gonna happen very sooner, like in the first month or second month. Mostly in the first month. She has already crossed the first month, which means the damage which might have occurred, might have already occurred. There is no way to prevent the spina bifida now, isn't it? So there is no use of giving folic acid now. Even if you give folic acid, the damage which might have occurred might have already occurred. You cannot stop it by giving folic acid. And now there is when do you start the ultrasound in pregnancy? It's usually 18 weeks, not prior to 18 weeks. So USG at 10 weeks is like a blunder. So what you will say? You will explain the patient, see, this is a neural tube defect which will happen in the first trimester, but you have already come very late to my clinic. At this stage, I can only reassure you because it has happened to you. It is not 100% sure that your baby will get it. So please stay positive and we'll hope for the best. That's all, isn't it? Any question? Everyone, any questions?
No. I want to ask that it means that the pregnancy ultrasound will start from 18 months. 18
Yes.
Weeks of pregnancy.
Yes. Unless there is any pathology.
But in this case, there's a definite chances that the child might have it, right? So, I mean, isn't it safer to do an ultrasound, and in case you can go for a termination if something is there?
No, we cannot offer termination. I mean, at 10, how should I say you? So even before offering any termination, you should first reassure the patient. See, you might have it or may not have it, isn't it? You will not take the patient to ultrasound and say you should go for termination. You will first reassure. See, it's not compulsory that if the patient has spina bifida, the child should get spina bifida 100%. No. I will open this for you. It's not compulsory. It's not 100% chance of transmission.
So they never do any dating scans or NT scans in Australia, is it? Like they never check for any of those things at around the 10 to 12 week time?
Yeah, at 10 to 12 week they will do this MMST. The next question is that. It's yeah. So where is it? The most common screening method used for spina bifida during pregnancy are second trimester. Done MSFAAP. But it's not ultrasound, so the screening should be done first.
No. So screening was the option. Can we give her that?
Yeah. But then you'll have to first reassure anyhow, because she already knows that she is spina bifida. Does that make sense? You'll have to reassure. See, whatever is going to happen. First, I'm telling you that because you have spina bifida, it is not compulsory that your child will have it. And there are like few tests available. I can do that if you wanted to do. It is not compulsory. You have to do it.
Okay.
Okay, next question. Pregnancy lady, any questions for this question? It is always reassurance. Australia is like so simple. Even though if you're not giving any management, even though if you're giving wrong management, it is always important to comfort the patient. Don't forget it. Okay?
Like reassure in the stem, we always have to go for that
Yes.
most of the time.
Yes. That is a very simple logic of Australia. Okay, next question. Any doubts for that question?
No.
Okay, great. Next, pregnant lady comes at 16 weeks of gestation. What to do? So John Woodcock says some of the first trimester, second trimester screening questions. Screening tests. So maternal serum MSST, which is done at 19 to 13 weeks, is ideal. What does it include? Free beta HCG, Papa, and if MSST is performed at 11 weeks and combined with NT 1 week later, it will enable the risk of trisomy and trisomy 18 to be defined and compared with age risk factors. So nuchal translance is another method. So you will know, you know all these, right? There's no way, but you have to remember them. When do you do amniocentesis?
16 weeks.
15 minutes.
I think 15 to 18 or 16 to 18. When do you do chorionic villus sampling?
20 weeks.
10 to 12.
10
chorionic villus.
Chorionic villus sampling is done, yeah. Amniocentesis is always the last one. And what else? What questions? I forgot to ask some question now. Yeah, let's see here. Yeah, the ultrasound, see, I said ultrasound should always be preferred only at 18 to 20 weeks unless there is a problem. Unless there is some pathology, like the patient is having bleeding. Even in Down syndrome screening, even if the mother or father is having Down syndrome, or if there is any family history of Down syndrome, we'll never ever say to go for ultrasound at 8 weeks or 10 weeks, isn't it? Do we say? We'll always give the screening test first and then do the ultrasound, because like in our countries like India or whatever, ultrasound is not easy here. There is a waiting period for ultrasound here. Got it? Any doubts with this?
Is there any test like NIPT in early trimester, 8 weeks or 10 weeks?
Nuchal transparency test, is it?
Non-invasive prenatal testing.
Oh, okay. I think it is not done here. I think it's obsolete now.
In 8 to 10 weeks, it's just the dating scan, no other ultrasound.
Yeah. Any other questions, please? And you will have to remember this too. When do you do OGTT? 28 weeks. 18 weeks ultrasound scan is a morphology scan. And you will do rubella anti-immunoglobulin test at 28 and 34 weeks. And group B streptococcus, like we call it as bug test, which is 36 weeks. These are important. They might come in later. Okay. OGTT, I think you might be knowing this, like OGTT is coming in exam anyhow.
So doctor, will you be explaining about that, because it's always very confusing as to in case there's risk factor and everything. Though for those with risk factors, we don't do it at 28 weeks, right? We do it a little bit earlier for them.
With risk factors, yes, you'll do earlier. This 28 weeks is like a normal routine antenatal screening. If the patient is diabetic, or if the patient have a family history of diabetes, then you will ask the patient to do OGTT, but I don't know what week is it. Maybe I'll tell you on Friday about this, okay?
Okay.
I'll have a question.
First antenatal checkup, we should done the OGTT.
Sorry, doctor.
Okay. In first antenatal checkup, we should do the OGTT in case of previous GDM or diabetic patient.
Okay.
The first antenatal checkup, just the blood sugars are checked. The fasting and random blood sugars.
Yeah, in case of high risk patient.
I will give you. That's a nice question. I'll discuss about this in Friday's class. Okay. I'll clear all this. Next, and if you have any questions related to those OGTT blood sugar levels, please post it to me. Okay. Next question. 35-year-old woman, 40 years old man have no pregnancy, even though they tried it for 6 months. She has every 28 to 30 days of last 5-day menstruation. Initial management not sure. Sorry. Okay, so what the stem says is that they are 35 and 40 years old people and they are trying to get pregnant in 6 months, but then there is no luck. So what is the most common cause of not getting pregnant? So when do you call the patient, the couple as infertile?
After 2 years.
6 months? Is 6 months a period for infertility?
No.
No. It's after 2 months. Sorry, 2 years.
2 years.
After 2 years. So they are only in 6 months. So in 6 months, they are coming to a conclusion that they are not getting pregnant. So what might be the cause? So the most common cause is infrequent frequency and time of sexual intercourse. So first you will evaluate the patient, ask the patient about their sexual life, and then you will see if everything is normal with it. Even then you will not go for semen analysis or serum progesterone if it is only 6 months. To do any test, it should be at least 12 months. At least 12 months of infertility. Then only you will offer tests. Otherwise, you will encourage them to practice the like the Billings method, ovulation, what we said, body temperature, basal body temperature methods, and encouraging the patient to know their fertile days. You will say all of them. Yeah. If these are not working and you have waited for 12 months, then you will offer the tests like the semen analysis and the serum FSH, LH, progesterone, estrogen, and everything. Thyroid test.
Excuse me, doctor, what will be the role of reassurance in these kind of questions?
Reassurance when the patient is not able to conceive, because these are about 30, 35 and 40-year people. If they are not able to conceive for more than even after 12 months, then you will directly go to tests. If it is less than 12 months, then you will reassure. Reassure stating that your frequency and time of sexual intercourse may not be correct. So you'll have to follow all these methods. And even after following all these methods, if you're not having any result, then I will do the blood tests.
So if in the question is this ABC, if there is reassurance also in the stem, so what should be the correct answer? What should we choose?
Tricky question.
That's difficult.
So, I mean, I will not go for reassurance, because at least I'll say them, I'll do what they can do. I'll say them what they can do without reassuring. It's okay. It will not be an issue. I'll not say that. I'll say, okay, maybe you'll have to revise your sexual plan. Okay. How does that sound?
Yeah, because I don't know, this is too much of controversy, because
I think there is no, as far as I know, there is no option of reassurance in this question.
okay.
Yeah.
You can give us some advice, I think so.
Reassurance is only when, so I have seen the reassurance option when there is some diseases related to the genetic conditions.
Yeah, there's nothing to do with the case.
Yes. When there is a simple answer, there is no option for reassurance. Clear? You will not get reassurance if there is like, if the answer is this, you will not get reassurance as an option. What will you reassure? How will you reassure? It's okay.
We can for something for the patient. That's why we don't want to do any reassurance now.
Well, the thing is, how it's practiced here, like 6 months is really a very small period of time, and that's what they usually say, that it's okay, it's just 6 months, and usually it's like 3 or 4 years. People get pregnant after 3 or 4 years, and that's how the doctors and GP here, if you go to their clinics, and that's what they tell you. So
no, don't. mean, don't relate the usual practice with this kind.
Okay.
Yeah, it's always good to say something because you're not giving medication or you're not doing any test. You're saying what they can do. It's always better option than reassurance, isn't it?
Yeah, it's okay.
Just a simple logic. Okay, next question. So don't worry, doctor. There is no option of reassurance in for this question.
Let's pray.
Next, pregnant woman complains of palpitations. A lab results TSH is high. Next investigation. So TSH is high in the sense? Yes?
Hypothyroid.
Hypothyroid.
But the symptoms are hyperthyroid.
Yeah.
Patient.
So this is like controversy. So what will you do? Think you have done this many times. So will you give thyroxine without knowing the disease? No, right?
No.
Why do you have to do thyroid scan?
No, not in pregnancy.
If there is any nodule, then you will do thyroid scan. See, I have written here. If there is nodule and the TSH is low, then you will do thyroid scan.
Also in the pregnant women, we will not give them dye in the
Radioactive scan.
Yeah. And if the TSH is high, then we will usually prefer ultrasound.
Rule out Hashimoto? Okay.
So, and to rule out Hashimoto's and Graves, how will you rule out Hashimoto's and Graves?
Is her antibody?
Thyroid and Graves will have this TSH receptor antibody, and Hashimoto will have thyroid antibodies. TSH receptor antibody is different, thyroid antibody is different. Okay, so before coming into diagnosis of Hashimoto's or Graves, you will do ultrasound.
How does that help us in management? Like, will it be for us to see if it's, it still doesn't help us to differentiate between anything, right?
So what? Wait, even I am confused now.
What will we expect to find in ultrasound if there is no swelling occurring, only the peak occurs?
So see, Graves is like Graves condition will have palpitation all over and TSH is not high, TSH is low. And Hashimoto's is like the patient will have initial hyperthyroidism and then the patient will go into hypo, isn't it? So this question, the patient is complaining of palpitation, but then the lab result has is showing TSH is high. So there might be a chance of Hashimoto's, isn't it? So to differentiate Hashimoto's from Graves, you will do ultrasound scan, and then even then, why is it ultrasound scan? Hold on.
What do we expect from ultrasound?
Yeah,
Because if it's an uptake scan, at least you know it's a cold nodule or a hot nodule, and you can.
nodule or hot nodule. Yeah. Okay, this is maybe I'll revise this question and get back to you on Friday. I have read all that big document and written this, but now I'm not able to remember. I'm sorry.
No.
I'll get back to you on Friday for this question. Okay. Okay. Next, 30 weeks pregnant lady having flu and cough, sudden pain in abdomen following cough on abdomen, and then there is on examination there is abdominal tenderness, vitals normal, fetal heart rate is 150, 145 per minute. Diagnosis. So here there are only two options. That's why we are choosing rectal muscle sheath hematoma. It's not placental abruption because the patient is not having any other symptoms like tender abdomen. There is only sudden pain, but the placental abruption, the patient will have pain all over. It's not sudden too. And see how this episode has triggered after the cough. So Placental abruption will not happen after cough. It is always there, isn't it? So sudden pain after cough, which means that there is some rectal sheath separation. We call it as rectal sheath divarification. Rectal sheath divarification is very common in cases of pregnant patients where there is twin pregnancy or the pregnancy is very huge. But here there is no option for rectal sheath divarification. We are choosing rectal hematoma. If there is option for rectal divarification, please choose it. Are you clear with it?
Yeah.
Okay. Yeah.
Okay, because rectal muscle hematoma. Hematoma in the sense there is blood bleeding in between the muscle, the rectal muscle. If there is blood bleeding, there will be tenderness at that side too. But here the patient is only having sudden pain in abdomen. The patient is not clear where the pain is. Is it in the abdomen or is it in the muscle layer? It is always a good option to choose rectal sheath divarification where the rectal sheath will not have any pain. It has only happened because of separation and whole tummy will have pain because of the separation. Clear?
Yeah.
And please be clear with this. It is always rectal sheath divarification, which happens in pregnancy. Okay?
Okay.
Are you clear?
Yes, yeah.
Yes,
Okay.
doctor.
Okay. Next, Arab woman comes. Arab woman who doesn't speak English with 16 weeks of pregnancy was referred by the midwife for which she suspects a mental condition. The woman seems irritable, worried about the people around, and she is uncomfortable when her husband is not around. She is also irritated with her 2 children. What condition or history will present to lead you to diagnose this patient? Okay, here the trick is if the patient is uncomfortable or irritated with the children, which means she is having some psychological problem. If it is only with the husband, she is not happy, which means there is some abuse at home. Okay, this irritated children is the key here. No mother will get irritated with the children except when the patient's psychological mind is not good. Okay. It is not panic attack because she is not fearing of anything. Her mood is irritated. It is not paranoid because she is not suspicious about her husband or suspicious about children or anything. And it is not trauma because there is no history of trauma in the stem. So it is prodromal symptom. Prodromal means like starting of a condition. It can be that it can be high likely chance that there is some family member with not only schizophrenia, any psychological condition. So that's why she is having this. Okay, because the option says family member with schizophrenia, we are choosing it. Clear?
Okay, thank you.
Next, see again this question has come. Baby born normal vaginally, no complication, everything normal with mild meconium passage. After 1 minute, baby cannot breathe. Cynosed, heart rate is 40. What most appropriate next step? Here the trick is heart rate is 40. Beta 6. So what will you do?
But regardless, anything, the next step is always oxygen bag mask, and then only we intubate. So
Yes. Always bag and mask. Whatever is there with you, you always pick it up. Don't wait for intubation. Okay? So this is the one which I found in Emidex. It is not, it is not that different, but I'll usually remember the first flowchart because I'll see it everywhere in the hospital. Okay? Next, only please remember 1, don't remember 2. Next, woman in labor with oxytocin drip in the first 4 hours, the cervix was dilated 4 centimeters and the head was 1 centimeter above the ischial tuberosity. After 3 hours, the contraction power was okay, but the head was still at the ischial tuberosity. What to do? So it is stuck above the ischial tuberosity. So, do you know that with the descent of the head, it is always the ischial tuberosity which is taken as the point, isn't it? If the head has reached the ischial tuberosity, then you will say the station 4. And then after descending from ischial tuberosity to down, you will say 0. You will say minus plus 3, 2, 1, 0, isn't it? When the head approaches the vaginal orifice, when you will say 0. When the head is at ischial tuberosity, you will say 4. So ischial tuberosity is the main point of outlet. The delivery is not said obstructed when the head crosses the ischial tuberosity. If the head is not crossing the ischial tuberosity, which means that the bony structure is not giving the adequate space for the head to descend further, which means this is obstructed labor. In case of obstructed labor, do you force the baby to go further against the bones by giving oxytocin, or do you stop it?
So I think level of the ischial tuberosity is station 0, and from that above -1, -2, -3,
-1, yeah.
and below from the ischial tuberosity +4, +1 to 4.
Yeah, at the level of ischial tuberosity it is 0. Above the level of ischial tuberosity it is +1, +2, +3, +4. Below the level of ischial tuberosity it is -1, -2, -3, -4. Okay. So ischial tuberosity is always considered as the main exit point for the baby's head. If the baby's head is crossing the ischial tuberosity and going down, then you will not call it as obstructed labor. Even after giving syntocin, and if the ischial tuberosity is, if the head is not descending any further, then you will call it as obstructed labor. So if the baby's head is not going down below the ischial tuberosity, and you are giving syntocin, but then there is no progress, what will you do?
Cesarean.
So first, before cesarean, what will you do? Yes, simple. Seize the oxytocin. Because you are planning cesarean, you don't want any uterine contractions.
Yes.
Clear?
So if that was below the ischial tuberosity, then do we go for amniotomy or continue oxytocin?
You will continue oxytocin.
No.
Okay. Clear? Is everyone clear? So always remember, whatever the question, there are many twisted questions about the same question. If the head is above ischial tuberosity and there is no progress, which means it is obstructed. If it is obstructed, take the mother to cesarean section. If you are taking the mother to cesarean section, before that, what you will have to do? Seize oxytocin. And there is another question.
Yeah, this was always very confusing. You made it very simple. Thank you so much.
And there is another question too, where the option is seize oxytocin, and the other option is give oxygen to the mother. Here the question is very clearly confusing. So, the options there is seize oxytocin, give oxygen, ask the mother to lay on the left lateral position, and the other one is cesarean section. So these 4 options will be there. What will you choose now?
This will be something with the delayed late deceleration or something, right? The CTG shows
something.
Seize oxytocin. Every question first seize oxytocin. Stop oxytocin. Because why is the mother needing oxygen? Because you are forcing the baby to push on the bones. So the mother is having distress with the bones, and the baby is also not having enough oxygen because you are asking the child to work continuously. So if you stop oxytocin, both the mother suffering and the kid suffering will stop. Okay, is it clear?
Yeah,
it's clear.
Next question. A 32 weeks lady comes with complaints of watery discharge per vagina. She had sex last night, and since then she was discharged. Since then there was discharge coming out. On examination there was straw-colored fluid. What is the straw-colored fluid? Amniotic fluid. So what it is? She is at 32 weeks. When do you call it as preterm? I've shown you before.
For 36 weeks.
before 37 weeks. So she is at 32. So it is PRON. Clear?
Yes, ma'am.
Straw colored urine is always amniotic fluid. Next, 16 years old presents with her mom with lower abdominal pain. Last menstruation was 4 weeks ago. Pain was severe. No indication for BP and pulse rate. What next? Beta HCG. So, why do you check beta HCG? Yes, to rule out pregnancy, and she is in the age group of sexually active. We don't know if she is sexually active or not, but it is always good to check beta HCG. Okay? It is a general rule to check beta HCG. Next, 12 weeks old pregnant lady was brought to the emergency department with vomiting, abdominal pain, severe bleeding for the past 4 hours. She also had 2 fainting attacks. Her blood pressure is 80/40. She was normal till before this episode, and USG at 11 weeks showed normal nuchal translucency. What is the most likely diagnosis? So here the key is normal nuchal translucency. If it is abnormal, then it can be hydatiform mole. If it is normal, then it is an incomplete abortion. Just simple. Okay. It is not complete abortion because she is still having bleeding and she is having pain. Her blood pressure is dropping. It is not abruptio placenta because abruptio placenta is a complication of 3rd trimester, not 2nd or 1st trimester. Okay. Ectopic pregnancy rupture, the patient will go into shock. And
there's an intrauterine. It already says ultrasound at 11 weeks shows.
Intrauterine. Okay. Even in ectopic and hydatiform mole, both will have abnormal nuchal translucency. Okay. But then the scan says it is intrauterine gestation. Okay. And hydatiform mole, as we did before, the tummy will be of very huge size.
Yes.
Okay. Next. So this is an interesting question. Pregnant at 30 weeks, comes to the emergency with right upper quadrant abdominal pain for 4 hours, but she develops the pain after 1 hour after eating hamburger sandwich. Blood pressure was 140/95, pulse normal, temperature is 37.3, there is no bleeding. Which one will lead you to the diagnosis? So what is this hamburger sandwich question? Does anyone know? So she's 30 weeks pregnant and she has got sudden upper quadrant pain because she was eating some fatty food.
So cholangitis.
Cholecystitis.
But then before ruling cholecystitis, because she is pregnant, do you think is there any other important thing which have to be ruled out?
You look pre-eclampsia, so you have to look for proteinuria in the urine.
Yes. So why? Because it causes HELLP syndrome. HELLP syndrome may also be the reason behind her severe tummy pain. Okay. So to rule out cholecystitis and HELLP syndrome, because HELLP syndrome is more severe, so obviously you will rule out HELLP syndrome first. To rule out the test to do urine analysis for proteinuria. Yeah. Okay. Is everyone okay with that?
Yeah.
Next, baby with a picture of cleft lip, which was diagnosed at 18 weeks by ultrasound scan, and what should be told to parents regarding further management? Because she was diagnosed for cleft lip at 18 weeks, do you recommend the mother to go for an abortion?
No.
Why?
We can repair it after delivery.
Yes, you will have to reassure the mother here, saying, see, there are many surgeries for the cleft lip, and cleft lip is not a big problem. The baby is not, like, there are many people who will have severe heart problems or spina bifida, like abnormalities. But then cleft lip is like a very small defect. So if you will be peritoneal success rate is very high. The mother will easily get convinced. You will not offer abortion. Okay, and amniocentesis is not needed because it is not the problem with what? It is not problem with chromosomal abnormalities or neural tube defects or Down syndrome. Okay. Shall we go to next question? Next, any woman 22 years of age was on carbamazepine is planning to conceive. Her symptoms are well under control. She comes to your visit seeking your advice. So we cannot give the option of continuing or cease carbamazepine without knowing for how long she is seizure free. Understood? If the patient is seizure free for 2 years, we can ask the patient to stop the drug. If the patient is less than 2 years, we can ask the patient to continue the drug. It depends on how long the patient is seizure free. Always remember 2 years for epilepsy, okay? So there is no right or wrong option here because there is no age group, there is no period given.
Even if valproate wasn't the option, we go for the same, is it? Or comparatively valproate is
same. Because, and the thing is, she is planning to conceive. She has not conceived already. We may, if the patient is having, if the patient is having the seizure, had a seizure within 2 years, then and she wanted to get pregnant in the next 3 months or 2 months, then we may consider decreasing the dose if it is carbamazepine. If it is sodium valproate is not indicated in pregnancy. So we will review that patient and then we may change to carbamazepine. Okay.
We can't suddenly stop the carbamazepine. We gradually check.
Yeah. So you have to always lower the dose. Okay.
But that is only when the patient has come to you and said that she has conceived.
Yeah, she is conceiving in next 1 month or she has conceived. Don't suddenly stop the drug unless the patient is seizure free for 2 years. If the patient is seizure free for 2 years, you can stop the drug. Got it? I'll write it here for you. Seizure free for 2 years, we can stop the drug. And seizure free for less than 2 years. So this seizure free for 2 years, we can stop the drug for any patient. If material of the patient is pregnant, or if she is planning to get pregnant, or if the patient is not planning to get pregnant, material. Okay. If the patient is seizure free for less than 2 years, if the patient not seizure free for less than 2 years. In case of normal patients, continue. Okay. And the same not seizure free for less than 2 years and wanting to be pregnant. She is wanting to be pregnant. Even then, what do? You will continue. Okay. And not seizure free for less than 2 years and pregnant. Reduce the dose. Okay. And sorry. Not seizure free for less than 2 years and pregnant on sodium valproate, what will you do?
Change to another drug.
Change to another drug.
Thank you.
Okay? Yeah?
Clear.
Yeah.
Sorry guys. Next question. Pregnant woman taking folate, what else she should take?
Iron.
Iron? C?
Iron.
Not
Protein is recommended. Oh.
No. See, JN says
Vitamin
differently.
D. I think
JN says
vitamin D.
differently.
iron should be.
Iron is not routinely recommended for healthy women if they are taking adequate balanced diet. Folic acid, we will give folic acid. As you know, 0.5 mg in normal people and 5 mg if there is any history of neurotube defects or history of epilepsy, or if the patient is on epileptic drug. And vitamin B12 is not routinely given. And the answer here is iron. Iodine is recommended. Okay, so iodine is recommended. See, the last sentence also says, as soon as possible by using iodized salt for cooking. If you are using iodized salt, it does not indicate that you should not give iodine, or you cannot, I mean, there is no need to give iodine. You should use iodized salt for cooking and also a multivitamin tablet that includes iodine. Okay? So iodine is recommended. So the answer is iodine. But iodine is not there here. If iodine is not given, what will you choose?
Vitamin D.
Vitamin D. Okay? Okay, because they need vitamin D here. Next. The 37 weeks pregnant lady with mild preeclampsia for induction of labor. Bishop score is 2. What will you do? So we have learned that it is prostaglandin. So what prostaglandin? Is it PGE1 or PGE2? Misoprostol is only used in the medical termination of pregnancy. It is not used in the normal deliveries. Got it?
Yeah.
So the correct answer we can only choose is PGE2, dinoprost. So that's why we are going for ARM after 12 hours, because only option which matches everything is this one. Because we cannot give PGE1 for normal delivery. PGE1 is only for medical termination of pregnancy. Okay? Am I clear? Please don't choose PGE1 anytime. Only in case of medical termination, and medical termination is not frequently done in Australia. Okay? Next. So we got this question too. Mother 41 plus 3 days with no abnormality. I have written this question like different ways only because I want to be clear. Mother 41 plus 3 days with no abnormality. Previous child born by LSES due to obstruction of labor. Post-dated pregnancy in all stages. Okay. So what will you do? Bishop score 2. What will you do? What will you do? So if there is bishop score 2, what you will do? You will induct prostaglandin. But then there is another option for admission for fetal examination. Is it making any sense?
Yeah.
Before doing anything, you will admit the patient for examination. Okay. So the answer is B. Yes. Clear? Do you want to continue or do you want to stop?
I think we should take some rest.
Okay. Okay, guys, how was my class? This is my first class.
It's very good.
So
Very
good.
You're very strict.
Oh, maybe my voice is like that. I'm not strict. I'm smiling and teaching, but I don't know.
No, it's good to be that so that we don't get straight and then we just don't keep pulling on for a long time. So
Yeah, you're right. You're right.
Okay, then.
Most important thing, you explain all the options, not only the answer but all the options.
And then you're giving us a good reference as well.
That's
Yeah.
the main.
Yes.
So I think we should take 10 minutes rest, then start again.
Today.
For today or for another day.
Next class, I'll give you 10 minutes break in between. Sorry, I forgot to give you.
and doctor, next class, can you just post this file a bit earlier for us so we can
Yeah,
print
sure.
it out?
Yeah, okay.
So I'm just asking, I'm seeing page 29 of 32. So we don't have many questions remaining, right?
Yeah.
Five minutes. We just finished.
Can you please proceed? Just finish this.
Yes,
Okay.
yes, Doctor can.
Okay.
Sorry, Dr. Fuad. I was thinking we just finished once and for all.
Yeah.
Okay.
Yes.
Because it's late in Sydney.
No, that's fine. So
Okay.
next 41 question is, which one of the following is most likely finding in a pregnant woman with placental abruption? So a patient with placental abruption. So what is the main classical finding of placental abruption patient?
Hard abdomen and tender uterus.
Tender uterus. So that's the answer there.
Yeah.
So decreased fetal movements. Decreased fetal movements is not a compulsory thing in abruptio placenta, right?
Yeah. Might be.
And
It can be, but the main thing is tenderness.
tenderness, uterine tenderness. That is the main differentiating point between placental abruption and placenta previa.
Yeah.
Okay. So always go for uterine tenderness. Next question. Pregnant woman at 39 weeks, no fetal movement, CTG pig given normal. What to do? So CTG here is normal and she is with you now. So what you will do? Yes.
Reassure.
Yes, because we did our part here. So she came to our clinic and we did CTG. We have already tested with fetal stethoscope and then we did CTG. Now CTG is normal. So what we'll do? Reassure. If you are not doing CTG and reassuring, then that is false. That is incorrect.
Yeah.
But we did CTG here and it is normal now. So reassure.
Yeah. There's another question saying that the patient is not convinced after the normal CTG. What should they do? Patient is not
Patient
convinced.
is not convinced. What are the options for the question?
After the revisit after.
Yeah,
the
ask
next-
her to come back after 24 hours. That's what we are doing here too.
If the same thing is at 42 weeks, can we induce her?
Yes. We can wait until 42 weeks here, and if the patient has crossed 42 weeks, we can induce. Okay. Yeah. I thought of explaining CTG, so I have inserted these quick pictures. I'll do CTG on Friday. I'll collect all the questions on CTG and do it.
So do they bring like a picture of CTG and tell you to interpret in the exams?
It's not that you will have to interpret. They'll give CTG and then they'll ask the management.
Okay.
Okay. Next question. A patient at 36 weeks gestation asking her friends say that she had decreased fundal height and that baby is not growing well. Which of the following will show that normal growth of the baby during pregnancy? So her friend says that the fundal height is not good and the baby is not growing well. So symphysia fundal height of 35 centimeters at 34 weeks gestation. So when she was at 34 weeks, the symphysia fundal height was 35 centimeters. Does that mean that the baby is not growing well? It's actually more. if she's at 34 weeks and the symphysis fundal height is at 35, it's actually more. So it is not an indication that baby is not growing well. The baby is actually growing well, isn't it?
Yeah.
And then CTG. What will you know about CTG? What will you know in CTG? Does the CTG will give the baby's weight and height?
No.
No. So the CTG is irrelevant here. So what you will do? You will do the ultrasound scan at 32 weeks, measuring the, what will you measure? Like the head circumference, abdominal circumference, the femur length, and then you will give the and then you will plot the growth chart. In the growth chart, as the option says, the baby's weight was at 50th percentile. So in between, what percentiles is considered as baby healthy? 3rd percentile to 97 percentile. Yes. So 3rd percentile to 97 percentile, 50 percentile is falling between 3rd to 97, which means the baby is healthy. What do you call the baby less than 3rd percentile? IUGR. More than 97 percentile?
Large resistance.
Large Okay. Now we have this rectal sheath diversification. 32 weeks gravid woman comes with acute.
Doctor, but that question, sorry doctor, that one is the patient is already at 36 weeks gestation, then how to do, so that you mean to say that the 32 week scan is, if it was a 70,
Yeah.
But even a continuously increasing fundal height, isn't that, that's not so reassuring because we don't look at all the features in that, right?
Yeah.
Okay.
It can be because of polyhydramnios. You cannot say that the baby is good. Got it?
Yeah, okay.
Can you please repeat the cutoff, the 3rd percentile to the 75th or 90th?
97.
97.
Okay. Next, 32 weeks gravid woman comes with acute abdominal pain. She was suffering from cold and after repeated coughing got the abdominal pain. Fetal heart rate is 145. I will send you this file, and if you go back, you will see the same question there too, where we solved it as rectal sheath hematoma. But as I said you, it is not hematoma, it is rectal sheath diverification. The option says rectal sheath diverification, please go for it. Okay? It is not rectal sheath hematoma. Rectal sheath hematoma will have localized pain too. Apart from the generalized abdominal pain, there will be localized pain too. Okay? And rectal sheath hematoma will be there only in case of trauma to the muscle. But rectal sheath diverification is most common in pregnancy with huge tummy. Okay. Next, female 6 weeks postnatal visit. She had threatened abortion at 6, 8, and 12 weeks. All examinations are normal. She had premature delivery at 24 weeks. Fetal weight was 550 grams. He died after 3 days. What is the cause of premature delivery? So here what you have to note the key point as 24 weeks. So what is the common cause of fetal death or preterm delivery in 24 weeks? When in the second trimester? Cervical incompetence. What is the common cause for the fetal death in first trimester?
Some chromosomal abnormality.
And what is the common cause for this fetal death in third trimester? There are many.
Lots.
Okay, that's simple. So the second trimester death is because of cervical incompetence. As you can see, placental abruption, acute chorioamnionitis is all because of will happen in third trimester. Fetal chromosomal anomaly in the first. Uterine anomaly, it can be noted in first or any time. Yeah, it depends on the size of the baby. Okay. All good. And because the examination is normal, all examinations are normal, we cannot talk about a uterine anomaly, isn't it?
Yeah.
Okay, that's all for today.
Okay.
I'll post the file in Maybe I'll give to Sharia sir. He will upload wherever. I don't know. Okay.
Okay.
Yeah.
Thank you. Thanks a lot.
No worries. Thank you. Have a good night. We'll see you on Friday.
Okay. Thank you.
Yeah. See you. Thank you.
Matron, I think you had your own